So when GPs assess eligibility for PrEP, it's important to keep in mind that we have guidelines on this from the Australasian Society of HIV Medicine, and those guidelines include advice on PrEP eligibility. And in a nutshell, this comes down to PrEP is suitable mainly for people who are at medium to high risk of HIV, and that includes people who have sex with casual partners without condoms, people who use methamphetamines, and people who've recently had syphilis, chlamydia, or gonorrhea. So most of this comes down to sexual history. So it's important for GPs to routinely take sexual histories from their patients, particularly for this patient, Michael. He has a few red flags. He is a man who has sex with men, and he's getting a little bit older. He's got some cardiovascular risks, and that may predispose him to some difficulties maintaining erections, which in turn may translate to difficulties using condoms. So for him, it's particularly important to ask him about his condom use and his sexual history. And as a good way in, to make it less confronting for the patient, I think it's important to normalize these things and say, Michael, look, you're getting a little bit older. You've got some risk factors around your cardiovascular health. People like you who have cardiovascular risk factors often have difficulties maintaining erections and may find it difficult to use condoms. Has this been happening for you? How have you been going with condom use? And is there something that, well, would you like some help in reducing your HIV risk with something like PrEP? So I think that's a good way in for this particular patient. But if a patient is specifically coming into your clinic asking about PrEP, then it's likely that they have some sort of risk for HIV. And that gives you a much easier in as well. If someone's already asking about PrEP, then it's very easy to move on to a HIV risk assessment and simply ask them, well, it's great that you've come in asking about PrEP. What do you think is putting you at risk of HIV? Well, there are two things that are really important for Michael. First, we have to absolutely make sure that he does not already have HIV. He's been having sex without condoms. It's possible that he already has HIV. And if he does, we don't want to start PrEP. PrEP is only 2 medications. It's not full HIV treatment with 3 or 4 medications. And if we were to start him on PrEP when he already has HIV, then we run the risk of making his HIV resistant to the PrEP medication. So that's the first thing that's really important. And that's just a matter of doing a HIV test today. That means he could leave your office with a prescription for PrEP. But then I would normally say to my patients, ring up in 2 days' time, get your HIV result. If it's negative, go ahead and start your PrEP. And that's an easy way around that conundrum. The second thing that's really important, particularly for Michael, is a renal function assessment. Michael has a few renal risk factors already. He's over 50, and we know that men over the age of 50 are more prone to getting renal problems as a result of taking PrEP. He also smokes, and he has pre-diabetes. So these things need to be assessed. We need to check his renal function on a blood test, so do a serum EGFR, and do a urine protein creatinine ratio. And in his case, I would also do a urine albumin creatinine ratio. The two are a bit different. So during PrEP use, we're more interested in non-albumin protein in the urine rather than albumin. But obviously, as a result of his pre-diabetes status, it'd be useful to also get an albumin creatinine ratio. So if we combine his urine protein assessment and his EGFR, then we should have a good idea of his kidney health. PrEP is contraindicated if someone has an EGFR of less than 60. The tenofovir in the PrEP can be renotoxic, so that's important to keep in mind. If it's over 60, then he can start. And in his case, he needs ongoing monitoring, obviously, of his kidney function. So kidney function and HIV tests are the 2 most important things. Then there are several other things that we should check on this baseline assessment. So we should check his hepatitis B serology, see if he needs to be immunized against hepatitis B. We should check his hepatitis C status, just because that's good practice in someone who's sexually active with casual partners. And we should do a full STI screen. So looking for chlamydia, gonorrhea, and syphilis. And with the chlamydia and gonorrhea, just as a little pointer note, just don't forget the throat swab and don't forget the anal swab for chlamydia and gonorrhea, because that's, if you're going to find it, that's where they'll be hiding. And then I would assess his immunization status. to make sure that he's immune to the hepatitis and immune to anything that might be going around at the time. So for example, in Victoria at the moment, we've recently had an outbreak of meningococcal disease, so we immunize patients with meningococcal vaccine before they start PrEP. So it's important when people start PrEP that they understand really clearly that in order for PrEP to work for them, they need to take it every day. So it's important that they have good adherence to taking the pill once a day. And there are several strategies that can help people to achieve this. They can get phone apps to remind them to take it every day. Some people may like to use one of those dosette boxes, you know, the ones that say Monday through to Sunday, just to remind themselves to take it every day. In Michael's case, this may not be such a problem. He's already taking metformin every day, so he probably already has a habit of taking pills every day. But if you're seeing younger patients who've not taken daily medications before, it's really important to discuss adherence strategies with them. So that's probably one of the most important things to mention to him. I would discuss side effects as well. In the short term, people can get some nausea, a bit of diarrhea, a bit of a headache, feel a bit tired. Those effects tend to pass over time if they continue using PrEP. And if they take the medication with some food, if they take it with a meal, then it tends to be much less as well. So I would let them know about that, because you wouldn't want patients to start their PrEP, feel a bit sick, and then just go, okay, well, I'm not going to do this. This is going to make me feel sick, and then stop, when in reality, those side effects would likely pass. The other things that people need to know is that PrEP doesn't work as soon as you take your first pill. So they need to take it for 7 days, every day, before they can rely on it to be effective at protecting them against HIV. And that's important, obviously, for them to know, so that they don't leave your office, take that first PrEP pill, and then go off and go to a sex party and think that they're protected. The other thing that people need to know is that PrEP does not protect them against anything other than HIV. So it doesn't protect them against sexually transmitted infections other than HIV. So we do encourage people to continue using condoms, or use condoms whenever they feel that's necessary in their sexual relationships to reduce their risk of getting other sexually transmitted infections. And that also highlights the need for them to come back every 3 months to do their sexual health screening as part of their ongoing PrEP monitoring, to make sure that if they get a sexually transmitted infection, that it's diagnosed quickly and that we can treat it quickly. So those things are probably the most important things for people to understand when they start PrEP. Patients who are on PrEP should come back every 3 months for ongoing monitoring. In Michael's case, he should actually come back a month after starting PrEP so that we can repeat his HIV tests and his kidney function tests, but thereafter every 3 months. And that's to provide ongoing HIV testing, ongoing kidney function monitoring, and as I already mentioned, ongoing testing for sexually transmitted infections. Now, during those visits, it's important to also check in with patients whether they're still happy to take PrEP, whether they have any ongoing side effects, and B, whether they still need PrEP. So, life changes. People won't always be at risk of HIV. People might find that they find the love of their life and they decide to move off into the forest together and not have sex with anyone else ever again. These things happen, and if that happens, then it may be appropriate to stop PrEP. So it's important to check in with Michael and say, look, how are you going with this? Do you still need it? And that's often all you need to ask. People often will reply to that and say, yeah, look, it's going really well. I feel much safer having sex. Or they might say, well, actually, I haven't had sex for a few weeks, or I've started using condoms, or I'm now in a relationship with someone and I'm not having sex with anyone else. But if people aren't sort of forthcoming and telling you this information, then perhaps just ask them whether they are having sex with casual partners and whether they're using condoms with casual partners, just to get an idea of whether PrEP should be continued. And if they don't need it anymore, then they can stop, and down the track they might need it again. And it's just important to leave that door open for people. If they decide to stop PrEP, they may need to come back at some point in the future and start again. This can be a difficult question. So Armando is a new patient to your practice, and he comes from what we can perhaps fairly assume to be a more conservative background. He's from the Philippines. He's recently migrated to Australia to work here. And it can be difficult to initiate these conversations with new patients. in some ways, but in other ways it can also be easier to initiate these conversations at this point before you really establish a relationship with them. What I usually do with patients who are new to my practice, I make it a routine as part of my routine history taking to introduce sexual history. So obviously when someone's a new patient at your practice, you would normally take a full medical history and you would take a social history that includes work and family and smoking and drinking. And if you're a bit more adventurous, you stray into the area of drugs and ask them about drug use. And I would encourage people to then also go on and ask about sex. Because this is the ideal opportunity to do this. And you can normalize it and say, look, I ask these questions of everyone who's new to my practice. Would you mind if I ask you a few questions about your personal life that are really quite important for me to know so that I can understand what your medical needs are? And then ask, do you have a partner? What's the gender or sex of your partner? Do you have any other sexual partners? And sort of gradually and gently getting an idea of what that person's sexual risk factors are. And I would say that's important with Armando, and hopefully that way you can bring up sex without him feeling confronted by what may be quite a difficult topic for him. So one of the significant barriers to initiating PrEP is people not quite appreciating that they are at risk of HIV. So as a clinician, I think it's important to get a good idea of that individual person's risk of HIV by asking an appropriate sexual history, and then really being frank with that person and saying, look, this is what's going on for you in your life at the moment. And in my professional opinion, from what you're telling me, it sounds like you do actually have a significant risk of HIV at the moment, and there is something that we can do to protect you against getting HIV. And in that way, being fairly blunt about this, because people do have solid defense mechanisms usually, and a lot of people who may be at risk of HIV may subconsciously deny that risk as a defense mechanism, and hence may not fully appreciate that they are at risk. Or they may simply not realize that what they're doing does put them at risk of HIV. So I think that's an important barrier to overcome when trying to encourage people to initiate PrEP when in fact they do need PrEP. In terms of adherence, I think in order to optimize people's adherence, it's important that they appreciate that PrEP is extremely effective. People are not going to adhere to taking a medication every day if they don't believe that the medication actually protects them against HIV. So you may need to explain to people that PrEP is extremely effective at preventing HIV if it's taken every day, and hence that it's important that if they're going to take PrEP, that they do take it every single day so that they are protected against HIV. So the other thing to keep in mind with this particular case, if we assume that Armando is from a socially conservative background, he may actually have increased stigma around sex, around sexuality, and around HIV compared to the average patient that you see. And such HIV stigma, or PrEP stigma as it then becomes, can be a significant barrier to PrEP initiation. So it's important when you're talking to Armando that you perhaps normalize PrEP use and reframe it, perhaps in a way to make it more health positive. And we can say things like, PrEP is kind of like the birth control pill for HIV, or PrEP is a healthy thing to do that helps you to protect your health and protect you against HIV, and frame it in a positive frame to try and overcome such stigma. So unfortunately, there are still segments of society where there is stigma around sex, around sexuality, and around HIV. And unfortunately, that stigma does translate to PrEP and to people who use PrEP. And it's important for clinicians to be aware of this stigma, because patients may come in or they may not come in. They may be worried that if they come and see a doctor, they will be judged for the fact that they are sexually active, or the fact that they don't use condoms, or the fact that they're gay, or the fact that they're at risk of HIV. So it's important for clinicians to be aware of this so that they can counter this proactively during consultations and make it very clear to their patients that this is a safe space, that they don't need to fear stigma, and they won't be judged no matter what they tell their doctor. That way you get honest consultations, and that way you can support your patients appropriately during the 3 monthly visits that are needed during PrEP use, where during these 3 months you have the opportunity to help patients with their mental health, maybe with some problems with drug use, or just general problems that affect their sexual lives or their lives in general. So PrEP does afford an ideal opportunity to support these patients appropriately, and these are patients who may otherwise not engage in healthcare.